I'm Nathalie van Havre. I'm the head of education at the European Hematology Association.
I'm Ali Taher, the director of the Blood and Cancer Center at the American University of Beirut, and my main interest is hemoglobin disorders, mainly thalassemia.
And we're here to discuss the Thalassemia International Federation guidelines for the management of patients with transfusion-dependent thalassemia. Ali, could you start maybe by explaining what is the Thalassemia International Federation and what are their goals? What is the scope of this federation?
Thalassemia International Federation, probably it's the only federation that takes care of all patients with thalassemia. It has been started in the 60s after the death of the son of the president of the federation, Panos Iglesias, through which this federation now is probably the most active federation, especially taking care of all issues related to the patients. And today we will be talking about the guidelines that were recently initiated, updated in 2022.
Exactly. So these guidelines focus on the diagnosis and treatment of the disease. And there has been a lot of changes recently in terms of diagnostic in thalassemia with the advent of new molecular genetic testing methods. Can you comment on this? Tell us what is required for diagnosis and in which patients?
So first of all, we need to define thalassemia, and we need to, thalassemia is an inherited disease. It's a disease that leads to anemia, and because of this anemia, these patients would need continuous blood transfusion for survival. And because the blood contains iron, we need to remove the iron by chelation therapy. And these patients are called TDT, or transfusion-dependent thalassemia, what we used to call thalassemia major. To diagnose these patients, it's a clinical diagnosis at the beginning, and these patients are usually anemic, with low hemoglobin, low MCV, small red blood cells. We rule out iron deficiency anemia. We do hemoglobin electrophoresis, and from the hemoglobin electrophoresis, we can know that this patient is a TDT or a minor, thalassemia minor. Once we diagnose it, we can confirm it by genetic testing. So the new things in thalassemia diagnosis is not to diagnose the disease, but to diagnose some of the complications of the disease, which is by doing an MRI and looking into the iron overload in the heart and the liver, using T2 star MRI and then LIC to measure the amount of iron. This is not really very new, but over the last 10 years, it has been worked a lot on it so that we can get the best results of these patients. So to diagnose the disease per se, it's a good history, family history, pedigree, a simple complete blood count, and hemoglobin electrophoresis and genetic testing. But to diagnose the complications of the disease, there are new methods, which I told you, the T2 star, the LIC, the bone densitometry, looking into all the complications of the disease.
Okay, so the T2 star, the LIC, and I suppose the serum ferritin are still what you use to diagnose and possibly monitor the iron overload, right?
Yes. As I started by saying that it's a disease where we need to transfuse the patient for survival. Transfusing blood contains iron, and this iron will be deposited in most of the organs, specifically in the heart, liver, and endocrine. This is why the T2 star is very important, because it looks into the amount of iron in the heart, which is the cardiac T2 star. The T2 star of the liver looks into the amount of iron in the liver, which we call it LIC, or liver iron concentration. And by having these two methods together with serum ferritin and good chelation, one would be able to know how to remove the iron, how much you need to remove, and how to address if we need to increase or decrease the chelation of these patients.
Okay. Are there specific criteria that help you decide when to start chelation therapy?
Usually in the guidelines we say after 10 units of blood transfusion, or if the serum ferritin is above 1,000. But currently, we're trying as much as possible to lower these thresholds so that we will keep our patients at a safe level of iron to reduce the toxicities, and mainly the heart, not only the heart and the liver, but also the endocrine toxicity of iron overload, because this will affect the growth, secondary sexual characteristics, and the fertility of our patients.
Mm-hmm. So I believe there are 3 agents approved for chelation therapy. Is there any preference over 1 or 2 of them, or?
As I always say, the most important thing is to chelate our patient, regardless. I mean, we come from different parts of the world. Some parts of the world have the luxury to use whatever they want. Others don't have everything. So the most important thing, and the lesson is, the take-home message is to chelate these patients. Mm-hmm. Now, some of them are intravenous, deferoxamine, diferiprone and deferazerox are oral. Some of the oral, like deferazerox, have film-coated versus dispersible forms. Currently, we will be moving into a new chelator, a new clinical trials. The question would be, do we still need chelators despite all these novel therapy? Yes. The presence of thalassemia is in what's called the third world, or the underprivileged world, where they cannot get access to all of the novel. So iron overload would remain a problem, and chelation would remain a solution for these patients.
Understand. So you mentioned novel therapies that may not be accessible everywhere. And I guess by that you mean allogenic transplantation and gene thalepy. Could you comment on which patients would be candidate for these treatments?
I think the only curative treatment for thalassemia is bone marrow transplantation or allogenic. So if they have an HLA identical donor, mm-hmm. or non-identical, being done in some of the centers, but mostly if they have a good identical donor, and the patient is not severely iron overloaded without a lot of complications, that would be the ideal way to cure the patient. Gene therapy is approved, but with a prohibitive price, so cannot be done all over, and we still need to wait time and see what are the adverse events of gene therapy. But what I meant by novel therapy is to address the pathophysiology of the disease, which is ineffective erythropoiesis, meaning that these patients have ineffective way in their bone marrow to produce red blood cells. So targeting ineffective erythropoiesis would address one of these issues to prolong the duration of transfusing the patients and to increase hemoglobin. And this is what we have seen in the new approved product, luspatercept, mm-hmm. which targeted ineffective erythropoiesis, prolonging the duration of transfusing the patient, but in around 33% of the patients. Yes, we still have another mitapivat, itapivat, and other products or molecules that target ineffective erythropoiesis. Hopefully the future will show us more and more results. Maybe combination therapy would lead, but all comes at a price. This is why I keep on saying that safe, good transfusion, keeping a pre-hemoglobin level of 10, chelating our patients properly is a must until these will be accessible to everyone and each individual in the whole world where thalassemia is mm-hmm. available.
So going back to luspatercept, what do the guidelines tell us? Which category of patients, and when do you consider starting it?
I mean, being an editor of this guidelines with some of my colleagues, we have replaced luspatercept in the algorithm of treating these patients. I think if it is available, it can be given to most of the patients mm-hmm. and see the response and see if you will keep on giving it or not, mm-hmm. as the approval says. But at least, in my opinion, patients that cannot find blood to be transfused, patients that have alloantibodies against the blood transfusion, patients that live in far places and can continue to come. So each country, I think, in my opinion, should have a group of patients where they think luspatercept would be the best for them. For sure, at the end, some of them will not respond and some would respond, but it's worth giving it a trial to our thalassemia TDT patients.
And is there a place for luspatercept in pediatric patients?
The luspatercept pediatric patients are moving on, and until we get the further efficacy and safety results, I don't think we should advocate using it. So once the data is clear and out, I think it will be, and that would be a very good a group, because these are naive patients with no complications, and you would see how this product will prevent at a later stage in their life the complications, unlike the adults where we are using it.
Mm-hmm. And thinking of the life cycle of the patient, we briefly mentioned earlier transplantation. Is that a treatment that is reserved to the young patients, or would you also consider using it in older patients?
The younger the patient is, the less iron overload they have, the better heart function they have, the cleaner liver they have. The HLA identical donor would be the best result.
Yeah.
But it doesn't mean that we can't do it for an adult, but the complications and the morbidities will be more. So chelating our patient, transfusing them very well at a young age is really the answer now to do a transplant until we have further data for all these novel therapies and where to have them. And so we're having a menu where we have several options for our thalassemia. I think this is an exciting time for thalassemia as well as sickle cell. With all these novel therapies that we are having, we need to wait. But from now until then, transfuse them well, chelate them well, and so that we will get the best results.
So the combination of appropriate transfusion and good chelation is what you would probably say is the best option right now for most of the world?
For most of the world, for those part of the world where bone marrow transplantation is not available or cannot be done, where novel therapies is not available, and there will always remain a group of patients who accept to be part of clinical trials. And I think that this is also another important message, because these are the patients that will give us answer to several unmet needs through which we could know what to work. But good transfusion and good chelation would remain now the treatment modality for the majority.
Okay. And does splenectomy still have a place?
If you transfuse them well and chelate them well, there is no need to do splenectomy, especially that we know that splenectomy has a lot of complications from infection, thrombosis, pulmonary hypertension. So when you transfuse them well, keeping a prehemoglobin at 9.5 or 10, and when you chelate them well, the spleen will not become very large. So splenectomy is reserved now to those huge spleens or to those patients that have severe hypersplenism affecting their bone marrow and having neutropenia, thrombocytopenia. And if somebody, for example, is a football player or something, and you're afraid that his spleen will be affected by the trauma, but it is not anymore a modality of treatment for these patients.
Okay. So to look after a thalassemia patient, I assume that it takes a multidisciplinary team. Who should be part of that team?
I mean, the best way to treat thalassemia is through a multidisciplinary team and in a thalassemia center where you have the pediatrics and the adult, for sure, starting with the nurse educator, the physician, the general physician, the specialist cardiologist, the hepatologist, endocrinologist for diabetes and bone disease, psychologist where they have a lot of anxiety and psychological problems because of their chronic disease. So these a dentist where we have, for example, in our side, a dentist because they have some dental issue, an ophthalmologist because some of the chelators will affect the eye. So from nurse educators, psychologists, to physicians, general physicians, to subspecialized physicians, to health economic people that are in the center, so that we will give the best for these patients. This is the centers that will get the best results and best survival when you look at them in a multidisciplinary, with a multidisciplinary team.
Do you feel that the prevalence of patients with TDT in Western and Northern Europe has changed with migration? And do you feel that hematologists in those more economically proficient countries have the knowledge to take care of thalassemia patients in general?
This is really a very important aspect, and I think it deserves a whole video or a whole chapter. As you know, the world now is really in crisis all over. We have a lot of migration, a lot of migrants, a lot of refugees. Most of them come from unprivileged places. And at those places, thalassemia is prevalent. So now they are in Europe and in the North America. And some of the physicians, especially in Europe, do not have the knowledge to deal with these people. This is why through IHA we have done some projects to make these people, these physicians, know better about the disease, the diagnosis and the treatment and the prevention, because we're talking about treatment, but ultimately these will marry, get carriers will marry and get more patients. So I think it's a very good project and worth educating these physicians, from general physicians into specialists, about the disease itself, the pathophysiology, the modalities of treatment. The refugees might be privileged that they are in these countries where they are receiving care, but some of the care should be better done through educating some of the physicians, which will see these rare diseases that were not at the time present in their countries.
Well, thank you very much, Ali. I think that's been a really interesting conversation, and I hope that it will lead to interest in education on thalassemia, and particularly transfusion-dependent thalassemia.
Thank you very much. Thank you for IHA for always including me in your educational way to educate physicians, and I'm always available and ready for any questions related to TDT or other diseases.
Always a pleasure, Ali.
Thank you.